I'm Mike Stitley. I'm a consultant gynecologist, and I work at Southland Hospital and through my private practice, Southern Gynecology Aotearoa, based out of Invercargill. And my specialty focus is treatment of urinary incontinence and pelvic organ prolapse in women. Reia first came to my attention when I was in a American Urogynecology Society conference in the United States. So it was a real innovation in pessary design. Pessaries had probably not changed in over 100 years. And a group of women engineering students at Dartmouth University were working with the gynecologist on instrumentation in women's health. And they were asked to explore different types of design for pessary. And what they came up with is really quite brilliant. So the traditional pessaries would be a ring pessary or a Gellhorn pessary. And these work well for many women with pelvic organ prolapse. A ring is a little bit less sturdy, can sometimes be self-managed by the patient, but many patients will have this pessary expel or come out if they are physically active, exercising, cough or sneeze, if they have a cold, that sometimes this is not a suitable pessary. And many pessaries are used in many elderly women who just may not be able to self-manage a ring pessary. They have difficulties with arthritis. It's not an easy thing to do for many people. Now, Gellhorn pessary is a little bit more rigid, and this is certainly not one that most women are able to self-manage. It's much more rigid when this sits into the vagina. And one of the things is this can put undue pressure on the vagina, so it needs to be removed, cleaned, and reinserted on a regular basis. And that requires some kind of a clinician visit, either GP, practice nurse, or gynecologist, to manage this pessary. The Reia pessary, and what's unique about its design, is it's collapsible for insertion and removal. And I have a little simulator and a sample device here. So it has an applicator that's available that not everyone needs to use, but it is available. So the pessary is placed in its collapsed position. The inserter is removed and push upwards to engage the position of the pessary. And what's clever about this is that if there is downwards pressure on it, the pessary actually expands in size, so it doesn't budge or move. So it has less resting pressure on it, but at the time when there is increased abdominal pressure, say from exercise or cough or sneeze, the pessary stays in place, but for removal, the patient can simply grab the ring and the pessary will collapse and remove. So it's really quite easy for patient self-care, and a vast majority of women in the clinical trial were able to manage the pessary. So it's really quite innovative. Well, I think with the Reia, the place that this will ultimately fit in practice is primary care. I think this is a pessary that can be fit and managed by GPs, practice nurses. Doesn't necessarily need to be managed by hospital gynecology services. And I think that's where it will be a real game changer, because access to gynecology appointments is limited and there are long wait lists in the public system, where if we can take patients that can be managed in the primary care setting using a device such as Reia, some women, many women, may avoid having surgery, and a lot of these patients are elderly and have other comorbidities, whereas a surgical repair might be quite disruptive or dangerous to them. And also eliminating the need for a lot of the ongoing, lifelong follow-up visits to care for a pessary such as a Gellhorn. Whereas when patients can self-manage the pessary, they're much more comfortable self-managing it and being home. And also for people who may live rurally, it's really quite difficult sometimes to go several hours to have a clinician manage a pessary on an ongoing, regular basis. Where if they can manage it themselves, I think that's a real benefit. And there can be some cost savings to the systems from the avoidance of some prolapse surgeries and the increased accessibility to gynecologic consultation appointments for other patients who may need them for other conditions. And there's also a fitting kit, so you can convert the sizing from a ring pessary or a Gellhorn pessary over to the size of the Reia. It comes in 3 different sizes, and the chart will allow you to easily transition from a different type of pessary. So if a GP practice has a ring pessary fitting kit and they're managing ring pessaries, they would be able to use that fitting kit to get the correct fit of a Reia and that would improve access to care for these conditions. The cost is definitely a barrier to access for this, and we've been working through our public hospital system to try and get this available, and we just haven't gotten there yet. But I do think that for selected patients, there's definitely cost savings from reduced burden on the gynecology outpatient services for frequent follow-up and monitoring of, say, a Gellhorn pessary, reduce emergency department visits from someone who is having bleeding or difficulty with a pessary, reduce likelihood of expelling the pessary and going through multiple different sizes to get proper fit. And sometimes proper fit doesn't occur and you end up with a surgery case. So I think that there will be a reduction of surgery, particularly in some patients who would be quite risky for a surgical repair, and reducing interfaces with the secondary and tertiary gynecology services for pessary care, where those appointments can be utilized for other women who have needs, and hopefully reduce wait lists.